Okay, thank you, Daniel. So it is a real pleasure and a great honor to introduce today's Grand Rounds speaker, Dr. Andrew Holman. Dr. Holman got his MD from University of Missouri in Columbia in 1987, which coincidentally happens to be the same year I got my MD. That puts us on par in our careers, I suppose. So after that, he joined the Presbyterian St. Luke's Medical Center in Denver for his internal medicine residency. And then in 1990, he came to Seattle to join our fellowship program, graduating from our fellowship program in 1992. At that time, he stayed on as a clinical instructor and at the same time saw patients at Valley Orthopedics Associates in Renton as a clinical rheumatologist. In 1993, he became a clinical assistant professor in our program and continued to see patients at Valley. Then in 2008, we brought him up to clinical associate professor in our program, which is a title that he still has today. In 2002, he also became the president of the Pacific Rheumatology Associates. And in 2006, he founded a company called InMedics, where he currently is the CEO and co-founder. And the topic of that company is, I believe, of great interest to all of us. It is the study of the autonomous nerve system and its effect on heart rate as a good measure, and the role of that in rheumatic conditions, including rheumatoid arthritis and fibromyalgia and a number of other conditions that Dr. Holman has studied and published on over the years. So I'm going to hand it over to him to tell you more about the role of the autonomous nerve system and his company's approach to monitor it and use it for clinical insight. So please, Dr. Holman.
Well, thank you, Thomas. Can you hear me all right? Yes, we're good.
Loud and clear.
Wonderful. So thank you, everybody. This is a bit of a homecoming for me, and thank you for all the guests for coming on to listen to this. I'm a clinical in the trenches rheumatologist, and I appreciate the level of academic stature of the previous speakers over the years at UW Rheumatology Grand Rounds, and it's very much a privilege to be among them and to give you a chance to talk about my topic. It's entitled Immuno-autonomics: How Autonomic Nervous System Stress Impacts Autoimmune Disease to Stratify and Enable Superior Therapeutic Outcomes. And although I am the founder and CEO of Seattle-based InMedics, I'm not going to talk about anything promotional today, but I will go over some of the science that underlies how we make the sausage, so to speak. Also, unlike most Grand Round talks that I've been to, as everyone gives their chronologies at the end, I figured I'm going to do it right at the beginning, and I wanted to make some important comments. So first of all, this doesn't happen a career like mine as a clinical rheumatologist, publishing papers and doing research in my office all by itself. And I was fortunate enough to work with Peter Simkin as a fellow. Peter was a profoundly gifted rheumatologist and just humanitarian. Taught me to really peel the onion and look for the pearls beyond the complex data. He got me started after Tom Petty at my residency program in Denver, very, very famous pulmonologist who taught me quite a bit as a mentor to question dogma. Now, he was my ICU attending. It takes a lot of chutzpah to question dogma in the ICU when people are on a knife's edge for life. But he put that in perspective. And then I've got to also give plenty of praise to Mark Manick, who brought me in to the program. And everyone realizes Mark's management style was serious, and it generated us to work hard and not waste people's time, and to get to the point. And I, like a moth to the flame in my entire career as growing a rheumatologist, I continue to look forward to talking to Mark about sharing my interests and my hypotheses. And he was always engaged, always interested, always listening. Not sure if he followed everything I was saying about fibromyalgia, but I can't thank him enough for those engagements. And then finally, Professor Rodney Graham in London, certainly a mentor for me. This is a picture from this year. Rodney is a leader in hypermobility syndromes and understanding the autonomic nervous system. More recently, I've got to thank Kevin Tracy at the Feinstein Institute at Lee Hood Institute for Systems Biology. They're on my board of directors. They are heroes of mine. I am standing on very tall shoulders, and I can't thank them enough for their generosity over the years and their encouragement. I also need to single out Harvey Moldavsky for his work in fibromyalgia, and especially Paul Peter Tack, who co-chaired the Immuno-autonomics study group at ACR for 5 years with me. And then you might be surprised that I have a fond affection for Donald Resnick because of some of the cervical spinal cord work that he did and that I did to elucidate how spinal cord compression affects autonomic states. So kind of interesting group. And then I need to make just a few final comments. Eric Sasso, we lost him, again, very serious rheumatologist. He was one of my early investors and one of my most notable sources of pride when he thought that I actually was onto something. Dan first took me aside for 3 hours to help me design a randomized controlled trial for pramipexole. I can't thank him enough. Bob Ettlinger has been a supporter since I was a fellow. I remember in Portland at the Northwest Rheumatism Society meeting talking to him about 20 years ago. Bob, I have an idea. I'm not sure he thought it was completely crazy, but he was listening, he engaged. Mark Genovese, also so important. Dan Efez, Lee Nelson couldn't have been more supportive. And then the team that took on fibromyalgia in Seattle, Steve Overman, Rich Neiman, Jeff Peterson, Rich Jimenez. And what can I say about Joyce Gauthier, about how I ruined all of her carefully designed clinical descriptions as a fellow and said, yeah, that's true, Joyce, but what if the patient was from Laos? How would that change your management and your diagnosis? Jan Hilson, who showed me that the kindness to patients, no matter what they have, is the most important thing we do. Jeff Carlin, a remarkable rheumatologist. Greg Gardner, Mark Wenner, Phil Meese, Rob Bennett, Mohammed Yunus. These are people who engage. They don't necessarily agree with what you're saying, but they engage and they're respectful, and they help me get to where I am. So thank you all for that indulgence. So I'm now working with scientific advisors from Harvard and Stanford and Oxford. And I want to single out Dom Toulouse, an internist in Seattle, who says to me, autonomics will be to this century what infectious disease was to the last. That's bold, but he might be right. We'll see. So let's dive right into it. I'm going to my black and white slides because now we're getting serious about things. You need to know everything I'm about to say is completely off label. There's data I'm going to quote, but none of this is FDA cleared for anything. You've heard about my disclosures, and my wife works for Merck, so I make sure you know that. In terms of objectives, I'm hoping after this hour you'll understand the fundamental interactions between the autonomic nervous system and the immune system, little neurology for us rheumatologists, to appraise preliminary evidence supporting how the ANS is a modifiable cofactor influencing rheumatoid arthritis, disease severity, and treatment outcome, and recognize the potential clinical applications for immuno-autonomic principles to improve patient care today and in the future. So I realize I've invited a lot of people, and I realize not everyone in the audience is a physician. So let's just take a moment here to step back to the basics. What is the autonomic nervous system? It's an important part of your central nervous system. Let's divide it up into two fundamental processes, the parasympathetic and the sympathetic. And the parasympathetic is the rest and restorative component. The sympathetic is the fight or flight activity, loosely described. And they're constantly active all the time, battling each other for predominance, depending on what the world is throwing upon you, what we call allostatic healing. That would include dehydration, gravity, lots of things. It has an integral impact on functioning for temperature, sleep, digestion, heart rate, blood pressure. We all know about running from the bear. You may not realize that increasing survival also means activating the immune system, which is part of what we're talking about today. Now, no grand rounds would be proper without a historical review. And I'm sorry I'm not there to see the fellows roll their eyes, but I'll just throw a few things out there. But this is not new. So there have been lymphocytosis with epinephrine was seen over 100 years ago. There are adrenal receptors on lymphoid organs. Some of the ones that are important to me is norepinephrine stimulates natural killer cells in the spleen. Behavioral conditioning affects immune function. Brain lesions alter immune function. And stress mediates pro-inflammatory cytokines. So basically, why should a rheumatologist be concerned or interested at all about the autonomic nervous system? Well, when I was looking at this and trying to figure out as a clinician, what could I do next after Enbrel came out in 1998, we had some marvelous responses, but it wasn't enough people. Certainly wasn't breakthrough. And we think of disease state impacting autonomic states. For instance, advanced Parkinson's disease has a very much detrimental effect on autonomic control. We all know about quadriplegia, of course, from trauma. So I looked at it the other way around. What about the autonomic nervous system as a neuroregulatory function similar to the endocrine system? Heaven knows we've had plenty of evaluation of endocrine issues in autoimmune disease. So is it possible that the autonomic nervous system could be an important cofactor in autoimmune disease expression and consequently the treatment response? And here's what lit the fire. 2000, Ellenkoff, Wilder, Trousseau, and so forth, sympathetic nerve. Integrative interface between two supersystems, the brain and the immune system. This is a remarkable, even to this day, review with about 400 references on how the sympathetic nervous system interacts with the immune system. The question then is, we know that systemic and local cytokine effects occur with the ANS. We know they're adrenal lymphocytes. I'm not going to go into the deep science. If we are lucky enough to have Kevin Tracy or someone, or George Trousseau or Wilder to come here, they'll do a far better job than I will on this. But as a clinician, this is what matters to me, the patient in front of me. And could I restore the balance of the autonomic nervous system as an innovative approach to the treatment of rheumatoid arthritis? You'll see Paul Peter Tack here, Reino Straub, and let's give Frida Koopman a lot of credit for the hard work she's done. So let's go right to the meat of the thing, and that's the cholinergic anti-inflammatory reflex. This is Kevin Tracy's work. This is one of the most cited papers that I see in my world. It links neuroregulation to immune function through the vagus nerve. And a little more detail on this, you may not realize, as I didn't, that the vagus has 75% afferents. So the brain is monitoring inflammation through the body. It is the command and control center. I thought the immune system ran autonomously because like a fetus, it gets what it needs no matter what. That's not true. The brain is the command and control center. And then 25% of the vagus is, it goes back down to the spleen. You all know about the cardiovascular and GI part. And it works on acetylcholine receptors and particularly gives us targets to try to understand this. This is the off switch, or at least the attenuation. This is the brake on the immune system. So it's led to this idea that could we harness the brain's regulatory function on immune activity to attenuate the overactive immune system that is harming our patients? You're all been very familiar with vagus nerve stimulation. There is set points work. There's Galvani's work at the spleen. There are some external vagus nerve stimulation ideas. Anything to hijack the parasympathetic to then reduce pro-inflammatory cytokines and T-cell activation. You may not realize there was also some work on the endpoint of the vagus, which is the alpha-7 nicotinic acetylcholine receptor agonists. These are acetylcholine receptors that are prominent, particularly alpha-7 in the central nervous system. And there was some very nice work on this that may be illustrative. Now, I want to thank Paul Peter Tack because he shared these slides with me. And I'm just going to delve carefully into some of the basic science. So you can get mice who don't have this receptor. Therefore, they don't have the vagus connection to the spleen to attenuate inflammation. And you can get them inflamed with a collagen-induced arthritis model. This was 2 groups of mice comparing wild type and the deficient mice. And some were sacrificed on day 44, some in day 63. Now let's walk through these 2 slides here. On the left is the 63-day cohort. On the right is the 44. And what you'll see in the circles is the knockout mice. And it's a clinical score. So the clinical score for inflammation that's going up in both groups goes up much higher in the folks who do not have this receptor. They do not have the vagus to attenuate the immune response in both these. So very interesting, at least from a immuno-autonomic point of view. They also looked at radiologic score in these mice, same story. You'll see that the wild type had less radiologic damage than the unopposed inflammation in the deficient mice. Also proteoglycan depletion score, same story. Now you can stimulate the nicotinic acetylcholine receptor, I love saying that, with nicotine. And if this is a different group of mice, if you do the same model and you stimulate with nicotine, what do you get? You get less inflammation. So activating an intact vagus nerve attenuates the CIA model in these mice. Also, they've come up with drugs that do the same thing, that activate this receptor. And you'll see on the right side, same story. So it looks like there's something very interesting going on here. Histologically, same story. In the saline group, far more inflammation than in the group that was stimulated with nicotine. And same with the alpha-7 nicotinic receptor agonist. Radiologic score, same story. Proteoglycan depletion, same story with the agonist. So this leads to hypothesis that perhaps we should be considering in humans who are suffering from an unchecked overactive immune system, this activation of the vagus nerve to try to block some of this immunosuppression rather than just relying on our immunosuppressants and steroids and so forth. So they started with mice, of course, and they termed this neurostimulation of the cholinergic anti-inflammatory effect rather than vagus nerve stimulation. There were 4 groups on the lower left here. And you'll see there was normal controls with no manipulation. There were normal controls who had the implant, but it wasn't turned on. There was the disease-induced rodents with an implant, but the implant was not activated. And then they had the disease-induced where the implant was activated. There was a period of time where they put in the implant, then they activated the inflammatory model, and then they made clinical assessments from day 9 to 16. So let's see what they found. So this is a very interesting chart. On the right is the days of inflammatory findings in the mice. On the left is ankle diameter over time, which is surrogate for inflammation. In the gray, where nothing happened, those are the normal controls, and that have the electrodes, but nothing happened. So the electrode didn't seem to do much. In the disease controls, who had the induced inflammation, but no vagus intervention, they had a rather aggressive inflammation. And then the stimulation group was somewhere in the middle, all statistically significant. So again, another step in the story, at least in mice. Other things that they looked for was inflammation, pannus, cartilage damage, bone resorption on the disease controls, and in the stimulated group, still statistically significant benefits in all of these outcome measures. So now we get to something that might help me with the human patients I see. And this is, again, Paul Peter Tech, Kevin Tracy, Frida Koopman, looking at vagus nerve stimulation in humans. This is an open label exploratory trial from 2016. This is using a commercially available vagus nerve stimulation unit that is FDA cleared for epilepsy. And the last time I looked, about 8 years ago, 100,000 people had used this. They stimulate this all day long to reduce epileptic seizures. I just came back from the American Autonomic Society meeting in Santa Barbara with a bunch of neurologists. I was the only rheumatologist, as you might imagine. It's very interesting. They were surprised that the protocol in humans is episodic stimulation, which has a profound, long-lasting effect, apparently, on the immune system, as opposed to its effect in epilepsy. But here's what they did, which was interesting. This is a 30-second single stimulation in patients with epilepsy who were having the implant, and they were measuring TNF levels. So pre-anesthesia here, they get a baseline. Post-anesthesia, but they put the implant in, nothing really changed. And then 4 hours after the vagus nerve implant, they noticed a significant decrease in TNF. So again, this isn't our patients, but they're trying to isolate the question as closely as possible in people who are asleep with as few confounding factors as possible. But it looks like in humans that this single stimulation has a beneficial effect on TNF levels. It had the same effect on interleukin-6 and IL-1. So now we've got 3 important inflammatory cytokines which seem to be impacted by vagus nerve activation. So now this is the human study. It's a little complicated. Let me walk you through it carefully. They put the implant in. They get it working. Then they stimulate it for from day 7 to 42. Then they have a hiatus. Then they restart again at 56 to 84 with extended follow-up. Now there's 4 centers in the EU. There's 2 cohorts. One is a methotrexate incomplete responder group of 7 people. And the other is a multiple biologic incomplete responder group of 10 people. And again, this is an open label, uncontrolled trial. And here's the interesting results they had. On the left is the DAS score. On the baseline is the days. And as you'll see that with the implant, there were some activity. And then you'll see that the greatest effect was in cohort, which was methotrexate incomplete responders. Then they had a hiatus. Then the DAS went up, and then it leveled off again with reactivation. With the biologic folks, as you might have expected, their response was not quite as robust, but still same pattern. So again, open label. They're now far advanced from this, but still a buzz around the ACR meeting about where's this going, and a deluge of companies diving into vagus nerve stimulation any which way they can approach it. They also plotted on the right side TNF, and you'll see at the same time. When it's stimulated, the TNF goes down. During the hiatus, it goes back up. And then when you stimulate again, it goes back down again. So again, we're getting some consistency here and some interest, even though the studies need to be tightened up in humans a little bit more. So here I am in my office in Renton saying, wow, I just love being a rheumatologist. I have this miracle called Enbrel and Humira, but then I have people in tears because it's not working. And it's not working. We're now addicted to remission. I wasn't a fan of low disease activity. I was trying to get remission. And what am I going to do? And I'm reading about all this, and I'm saying, well, I'm studying how the autonomic nervous system is active at night, fragmenting deep sleep in fibromyalgia patients. And I make the observation in about 2001, I think that's when I first presented it, that some of the newer ideas in fibromyalgia to reduce the autonomic hyperadrenergic inhibition of deep sleep were starting to work for fibromyalgia pain scores. And that back then, no one really was willing to say that you could have fibromyalgia with rheumatoid arthritis. Now we all accept it, of course. But at the same time, the folks who had rheumatoid arthritis and fibromyalgia, their etanercept seemed to be working better if the autonomic intervention was playing a role in reducing their sleep disturbance and improving the fibromyalgia. My first reaction was I'm getting fooled. Fibromyalgia amplifies symptoms. So the tenderness of their joints is simply less tender because everything's less tender. That didn't seem to pan out, especially with the inflammatory cytokines and ESR and SED rates and all the work everybody else was doing. So we looked into it a little bit more. So here I'm going to transition a little bit to a little more clinical. I'm going to say, okay, so you're interested in the autonomic nervous system. How do you do that? Well, heart rate variability may take you back to maybe about 15 minutes of discussion in medical school. It is a normal reflex of the cardiovascular system whereby respiratory pressure changes in your chest with inhalation and exhalation changes your heart rate. So as you breathe in, you reduce pressure within your chest to draw in air. That expands the aortic arch just a touch. Now remember, the aortic is a fluid-filled space. So if it expands even slightly, baroreceptors are going to register a slight decrease in blood pressure in the aortic arch. That sends a signal to the brain to accelerate the heart rate. So as you breathe in, your heart rate accelerates. As you breathe out, the opposite occurs. About 5-10 beats in a normal person. What was observed many, many years ago, hundreds, was that when people are under stress, that the heart rate turns into a metronome, that phenomenon of respiratory arrhythmia, it disappears. So looking at the variability between the beats has become, very important for certain areas of autonomic testing and neurology and cardiology, a little bit new to rheumatology. So there are 1996 international standards. These are codified by electrophysiologists worldwide. This is what you'll see in every paper. If you do a PubMed search, you'll see 50,000 peer-reviewed articles on heart rate variability using these 1996 international standards. And as you might have guessed already, the simplest is the standard deviation between beats. So if they're all the same, the standard deviation is 0, right? So if they vary, the standard deviation is higher. But then they made up all kinds of crazy stuff, like the RMSSD, the root mean square of successive differences, the NN50. I won't go into this. And then they did Fourier transform of the data to look at frequency domain. And they found that if they look at different frequencies, they can identify just a little bit more information, particularly a high frequency band and a low frequency band. And they have found that the RMSSD, which if you have a Whoop on or an Oura Ring or a Garmin, they measure RMSSD as a measure of heart rate variability, usually while you're asleep. It's a time domain, very simple thing. High frequency is also well thought of in the literature. So going back to using this test, if you have reduced heart rate variability, it's more like a metronome. It is closely aligned with increased fight or flight autonomic activity, adrenaline, if you will, for those non-physicians. And that has a direct effect on inflammation, cytokines and T cells, the Ellen Unkoff-Wilder article and others. And that leads to overwhelming our immunosuppression and giving us a suboptimal response. Now, I'm going to make 2 points here. One is the reason you can't use your Garmin and your Oura Ring is because you need a high fidelity EKG to do this, or ECG. You need to know exactly where the heartbeat is. And so you have to sample the EKG at least 500 times per second to be able to identify the top of the QRS and isolate it. Apple Watch, for instance, samples at 150 hertz, which gives you somewhere in between here an approximation. The best cardiac care units in the world are at 250. 330 is here. You need 500 or more. This is an illustration of comparing photoplethysmography, which is that green light underneath your Fitbit, that looks at a pulse wave to identify your pulse. And that's in blue down here. If you run a concomitant high-fidelity ECG, you get this right here. Now, usually I can blow this up, but I'm not able to here. If you overlie them, what you'll see is the peak of the photoplethysmography beat is not very well aligned with the EKG. In fact, it goes forward and back and forward and back. It's a complete non-starter because the difference in beats is in milliseconds. You can't tolerate that kind of sloppy error in identifying where the heartbeat is. So you have to have a precision EKG instrument. Now, the next thing is I want to show you what I've been working on is this is the next generation of heart rate variability. This is beyond the 1996 international standards. This is what's used. The Super Bowl, Seattle Seahawks used it. Half the NFL uses it. Premier League uses it. Lionel Messi trains with it. Comes from Soviet Space Agency. Val Nastikin, a very good friend who started Omega Wave, allowed me to use this 20 years ago because I said, you know, Val, if you say it really measures autonomic state, I want to do some studies with it. And I did 9 clinical studies with it. You'll recognize that it provides the SDNN and the time domain. It gives you the frequency domain. That's fine. But it also has these things you may not have ever seen before. Parasympathetic activity, sympathetic activity, and tension activity. I wouldn't worry about these two here because even I don't know what those are. It has something to do with sports. So Baevsky, R.M. Baevsky, famous, iconic mathematician who was the sort of the pioneer of Russian cosmonaut training, found that if the problem with HRV was you had measures that could identify a reasonable surrogate for parasympathetic, but there was no measure of sympathetic fight or flight activity, which is also important. And he solved the math. And that's why we have a sympathetic tension index here. Also, we upgraded the parasympathetic. So I got this in my hands, and I did comparative testing in the field of rheumatology. One of the early things I did was which I won't review here, I could do a couple hours on fibromyalgia. But there's already been plenty of HRV work in fibromyalgia by Martinez-Levine in Mexico City, and showed that it's a hyperadrenergic state that fragments deep sleep, and they've used HRV and so forth. I was able to say, yes, exactly. It shows all that. It correlates with fibromyalgia activity as well in treatment response. But I looked at an interesting group because I want to know why patients responded differently to the same treatment, particularly my rheumatoid arthritis patients. So I very carefully excluded any comorbid hint of fibromyalgia, which was not easy to do, but I was familiar enough with it. And I looked at 31 consecutive patients who had a swollen tender joint count composite score of less than 4. And I found 31 of them. And basically, I asked a simple question. What does HRV distinguish who can respond very well to a combination, as we were all taught to add etanercept to the combination of DMARDs, or did it distinguish the people who were able to wean off those DMARDs, because that was the first thing I did with steroids and methotrexate, if they were doing well? We compared the 12 DMARD etanercept responders versus the 19. Here's comparing mono and combo with all these different variables. There were no significant differences in the group. They were all doing great. But here's the take-home point. We did the Beck Anxiety Index score because it has an autonomic score held within it. Both of it distinguished the groups. There was less autonomic activity in the etanercept monotherapy group. In the monotherapy group, the vagus was higher, which would be consistent with less driving of the immune system and requiring less immunosuppression. Sympathetic, same story. Tension index, same story. Total power, which is the 1996 HRV that we did trended, but was not significant in this small pilot study. And that's the problem with 1996. It's a blunt instrument. It's great if you have a group of 2,000 people looking at cardiovascular risk, but to tell you what to do with the patient in front of you right this minute, you need greater precision. It's the difference between an ultrasound and an MRI. So then we got serious. And we did prospective double-blind study, looking at patients who are inadequate responders to methotrexate advancing to a TNF agent. We checked the HRV, blinded it, and we took care of these patients for a year. And here is the ACR 20, 50, 70 outcomes for those with looking at parasympathetic quartile, which was the best data. Those who had a low parasympathetic Baevsky output had an ACR 20 response at 6 months of 40%. Now, as you may recall, the registration trials had 65, 70% just to get on the market. The ACR 50 was 12%, the ACR 70 was 0, and it was durable for a year. And those people who just happen to be wired with a higher parasympathetic quartile, because we don't know what normal is, we just put them in quartiles, had 100% ACR 20. had an 88% ACR 50 and a 65% ACR 70, and that was durable as well. So this helps us with associative. It seems like it's associative, but it's not quite there with causal yet. We dig into it a little bit further. Mark Genovese was very kind with his time and advice to say, look, we need to dig into this a little bit further. Why don't you look at this in terms of area under the ROC curve? And as you see here, week 6, 12, 26, 52 in 4 different outcomes. As you run the immunosuppression longer, you start to see more discrimination of prediction. And what you'll see in the 2 leading Bayevsky outputs of parasympathetic and tension index is area under the ROC curve of 0.926 and 0.918. So very, very compelling numbers to prompt us to look further. You can also take these this data in a double-blind prospective study and find these coordinates, and take these coordinates from the data and plug it into the formula. Now, this is Edmund Ning's work. He was my statistician for everything I do. He did the Kineret data at Amgen. Very, very skilled Seattle biostatistician. And you can actually take a parasympathetic score in a patient in front of you at 0.119, run it through the data we already have, and predict that they're going to have a 84% chance of reaching an ACR 20 at 26 weeks with a large confidence interval. Now, this is a starting test. The more patients you do, the confidence interval will come down. But this just gives you some idea of, does this matter? Seems to. Can we do something about it? That's the next question. So I presented this down here in 2004-07. There wasn't a lot of HRV questions with autonomic stuff, but you can see it's increasing substantially over time. It's not the kind of numbers that we get with a cholinergic anti-inflammatory reflex or some of your other papers, but it's coming along. You may have heard this. This was a press release. Setpoint Medical, they using their own little gizmo, inserted into the neck, stimulating the vagus nerve. Top line data suggests that that in humans in a properly designed registration trial, looks like this may be the real deal in helping our patients with autoimmune disease. But a couple of things you probably never saw. So I'm in the trenches doing what I can, and I'm looking at people, and I'm saying, what if I just take people who start etanercept, and if they don't respond with primary outcome, which was greater than 70% reduction in total 28 swollen tender joint count. Now, in retrospect, I would have used ACR 70, but I didn't do it. But at least it's a pretty robust outcome. And if they don't respond, I'm going to start throwing the restless leg drugs at them that have been pivotal in reducing autonomic hyperadrenal activity in fibromyalgia. And after 20 months, 92% of a cohort of 60 patients were still on their etanercept and had achieved that outcome 79% of the time. I mean, it's quite striking. And 75% had discontinued methotrexate, 62% had discontinued prednisone. Now, it's very preliminary data. We need to have a proper study. And I don't have HRV data with this, but it leads me to where we're going to go next. The other study which got my attention in 2003 came from ACR in Orlando. And this was Shimizu's study. I'm sorry he didn't publish the paper. I wish he had. But what he did was he looked at 96 consecutive patients with rheumatoid arthritis. And he sent them to the sleep lab, formal sleep lab. And he found 51% had obstructive sleep apnea by international criteria. These are predominantly Japanese women who don't snore, aren't overweight, aren't tired, don't have morning headaches. And I go, holy smokes, maybe we need to rethink our risk factors. What was also interesting to me is he treated those who needed it with CPAP, and in 7 who continued for 5 months, without changing the rheumatoid arthritis therapy, which was pre-biologic, the mean reduction in CRP and joint count was about 35%. Sleep apnea is a very well-studied, potent autonomic arousal, hence its effect on cardiovascular health. Sleep apnea untreated is equal to cigarette smoking in the Sleep Health Heart Study as a cardiovascular morbidity risk. So I got interested in a couple of things. One is I better start checking sleep studies on people who don't look like they need it. I can't miss this autonomic problem. And I wrote a couple of papers in editorial that maybe we should think about this, because we were spending a lot of time talking about the cardiovascular risk of RA patients that was not attributable to the Framingham risk factors. And we started making that leap across the chasm to say, oh, it must be inflammation because we all study inflammation. I would say that could be true, but we might also want to look at the autonomic state and make sure we don't ever miss sleep apnea. So the paradigm here that as a clinician in the trenches was, we diagnose, we'd educate. That's one of our strengths in rheumatology. We'd select treatment, at least if the insurance didn't do it always for us. The simple difference that I proposed was maybe we should check a precision measure of autonomic state so that we at least throw that into the hopper, so that we don't let autonomic arousal torpedo what might be an otherwise effective immunosuppressive strategy. As simple as that. Now, I want to leave you with something very interesting, because we're all talking about the risk of patients developing RA. And this is, again, Frieda Koopman, Paul Peter Tack, coming through like the cavalry again in this field. They looked at the at-risk population we're all aware of. About the work in Colorado. You know about trying to prevent new onset RA and with multiple drugs. You know about the hydroxychloroquine didn't work quite so well. However, they looked at rheumatoid arthritis risk factors, and we're looking at resting heart rate and HRV. This is the old HRV. Turned out resting heart rate was higher in individuals at risk for RA and in individuals who subsequently developed RA compared to age-matched controls. So on the left side here. Then they did a validation cohort, and they found the same thing. So training and the validation. What got my attention, of course, was the HRV. They looked at the standard deviation, the very basic of basics, and the RMSSD, which is a little more common in the commercial unit, or the consumer units. And they found that, yes, there was a significant increase in resting heart rate, hyperadrenergic, and a reduction in HRV that also reflected hyperadrenergic. So we know that rheumatoid arthritis is genetic in some respects. It's 30% concordance in identical twins. That's a big deal, but it's not identical. We know one of my favorite facts, which I hope is still true, that there were no rheumatoid erosions in Europe before Columbus, and they were in North American bones as long as anybody's ever been here. So it looks like a transmissible entity of some sort. So is it possible that with the right genes and the right exposure, which is probably now ubiquitous, that it takes an autonomic arousal in the background to fan the flames from a subclinical response to that exposure to develop an ongoing sustainable disease? You can imagine that if I can get anybody with a at-risk group to do it, I want to look at autonomic state and follow them over time and see where that pans out to. I'm also particularly interested in how autonomic fluctuations, because it fluctuates in your life, may contribute to MS flare and lupus flare. So I'm just going to wrap up here and make sure there's time for questions, but I just want you to have some idea that immuno-autonomics may have a role in oncology as well. And I'm not an oncologist, but I'll show you just a couple of papers that made me sit up a little bit. This is the Zutphen study, Netherlands. 2,356 middle-aged and elderly men tested in 1960 with the most primitive of HRV and followed over 25 years, simply for survival. Those who had a favorable autonomic state, so a more favorable variability, survived 60% of the time. Those who had the more unfavorable inverse survived 40% of the time. The point of this paper was not to confirm that stress is bad for you and could contribute to longevity. The point was why they died. They died of cardiovascular disease, yes, but they died of cancer. They died of cancer. We know that stress responses and autonomic state affects immune activity and autoimmune disease. To my simple mind, it looks like pouring gas in the fire. But in the oncology world, in the non-rheumatology world, it may be more of a dysregulatory force. And is it possible the stress response impairs the immune system's coordination for surveillance? Just throwing it out there, work to be done. But if you look at people who actually have cancer, and I'm just finishing up here. This is out of MD Anderson. 520 patients with solid and hematologic cancers, looking at survival out to 300 weeks here. There is a significant difference in survival, 40 versus 55%, depending on your autonomic state when you start this study. Now, let's be careful. Let's look at confounding variables, as we always should. This was not next-gen HRV. This was old HRV. And is it possible that those people who had poor heart rate variability could have been sicker, and maybe they couldn't have taken all their chemotherapy? They couldn't have had the benefit of the oncology treatment. We don't know. I scoured the papers to try to figure that out, but that wasn't in there. But it's still interesting. How about pancreatic cancer? The difference between 3-year survival is 10 and 20%. It's terrible, but I'd rather be 20% than 10%. And what they haven't done in oncology yet, which we have now done in rheumatology, is to stimulate and reactivate and optimize the autonomic parasympathetic. Is it possible that if we take these people with a poor HRV, we convert this poorer survival curve to the beneficial curve? And because it's actually survival, not just remission and everybody's happy, is it possible that we could optimize parasympathetic more than natural and elevate this curve further without even coming up with a new treatment for pancreatic cancer? Now, that's lofty goals, but it's not a hard thing to study. And now I believe we have the tools in terms of intervention and also diagnostics to actually start to answer those questions in oncology. And then the one that really is the last one that really gives you some pause is this is lung or breast cancer mets to the brain. 40 people, very sad, everybody died. But they looked at SDNN again, the most simple autonomic measure. And those who had a favorable HRV survived 22 months. Those who had the unfavorable inverse survived 13 months. That's a 9-month difference in survival. Now, I don't know how many oncologists we have on the call, but it had to be explained to me that the FDA is looking for a 3-month extension in survival for a blockbuster breakthrough. This is 9 months. This is far exceeds that. And again, same caveats. This is pilot data. It was the beginning. But is it possible that we may help our oncology friends by pushing this further, not with the immuno-oncology in its traditional sense, which is fine, but just optimizing the autonomics so it doesn't torpedo the effectiveness of other treatments? And of course, you may also ask the same question about cardiovascular treatments and all kinds of other things for which stress may impact. So I don't know if you realize last week was International Stress Awareness Week in the UK. Thank you, Dan Austin in Medics UK for sending this to me. But I want to thank you all for letting me share this as a clinical in the trenches rheumatologist. And I particularly appreciate publicly the opportunity to thank those wonderful teachers and mentors who helped me get to where I am.
Thank you very much for a really fascinating talk. I'm going to kick off with one question from me. So if I was your patient and I had a very low HRV and ailments, and I would ask you, so Dr. Holman, how do I improve my HRV? What's your top advice?
Yeah, so if I'm serious and you have rheumatoid arthritis or lupus or MS, you're going to the sleep lab as fast as I can get you there. I don't care if you snore or not. I've been getting sleep labs at Virginia Mason for 20 years, like thousands of them, and it bears out. The next is I would talk to you about restless leg syndrome, bruxism, other manifestations of autonomic arousal, palpitations, try to get a good history. And then I would put you on just a week's course of either low-dose lorazepam or clonazepam, and happy to go into the details of that. Again, no daytime use, no daytime. And then just to round it off for our Pacific Northwest audience, as I do, that the patients come in and we put them on injection, they're on steroids, or on methotrexate, they're on blood testing, right? And they say, "Doc, can you give me something other than a pill?" Right? And I say, "Yes, now we can. You can try Tai Chi, meditation, yoga, exercise, eat right. You can do all these things are good for you. But here's the caveat. We're going to recheck your next generation HRV in 6 weeks to see if you're making any progress. Because if your numbers are not improving, it's like you can lower your salt for blood pressure, but we're going to check you to see if it's working, right? That's the difference. And so all of the things are on the table that you are already thinking about that might treat autonomic state.
Okay, thank you. We have a question from Grant Hughes that I'm going to read. Thank you for this fascinating presentation. Do you know if autonomic signals result in epigenetic changes within immune cells? Are these changes persistent in long-lived cells like T cells and plasma cells?
I don't know, but I've been thinking about it, and Lee Hood and I have been talking about it. So one of the reasons Lee's on this is, you know, it's exciting to see someone who's accomplished so much still have a twinkle in his eye when you talk about something new. And we are talking about the autonomic nervous system as an adaptive system to help you survive. And one adaptive response of your genomics is epigenetics. So we are all over looking at that. And I'd love to talk to Grant about, you know, how Lee and I and him, maybe we could talk more about how to sort that out.
Okay, thanks. Here we have a question from Andrew Solomon. Have you looked at the possible immune checkpoints where the immune system and autonomic nervous system interface? Is the KP pathway important, in which inflammation shunts tryptophan away from serotonin into quinolinic acid, which is neuroinflammatory and neurotoxic, for example?
Andy, it's nice. I hope you're doing well. Thanks very much for attending. You're asking the wrong guy. I'm the clinical guy. In fact, if you'd called me, Andy, I would have paid you $10 not to ask that question. So, so I have to beg off on the basic science, but I'd love to refer you to Kevin Tracy. I bet he knows the answer.
Okay, then we have a question from Nadine Elayash. How does next-gen HRV measure heart rate variability? Is it a wearable device? Are the Oura Rings Apple Watches useful for patients to measure their HRV?
Yeah, excellent question. A very common question as well. So as I showed with photoplethysmography, the fundamental basic of HRV is knowing where the heartbeat is to measure the millisecond differences between beats. And you just can't start with current technology that uses photoplethysmography. You have to have 500 hertz ECG. We've talked to Google and Fitbit about combining our resources with our proprietary math with their advances, but it has to be invented for a wristwatch. So right now it's a point of service test done in the doctor's office with a special EKG machine. In terms of how do you do it, it's the math that goes beyond Fourier transform and frequency domain HRV. It's all proprietary. So offline, I might be able to talk to you a little bit about it, but there's only so much I can share.
Okay, then we have a question from Robert Ettlinger. There is much discussion of difficult to treat RA and which are inflamed and which are not. Would HRV be helpful here?
Yeah, so thank you, Bob, and thanks always for your support over so many years. Yeah, it's we all run into this. So the first thing I look for in difficult to treat RA is, am I running up against a hyperadrenergic state that people are just wired that way? Or has life made them that way? One caveat I will remind everyone is when you do a double-blind prospective study, which for those of us in the trenches don't do that very often, not in our own study, you learn something very interesting. I thought I knew the stressed people in that pivotal study that predicted outcome after a year, and I was wrong. The people who I had followed for a year and then unblinded the data, those who had a sympathetic profile often didn't look like it. This is not behavior. This is not anxiety, although stress affects it. This is a silent thing like hypertension. So be very wary, even with the best of clinical skills. You cannot tell who these people are who have increased sympathetic tone. You have to look at resting heart rate, HRV, things like that.
I'm going to ask you a question as well here. It's known that patients of indigenous origin have greater prevalence and often worse and harder to treat rheumatoid arthritis. Does that correlate with them also having a higher HRV or lower HRV, I should say?
Yeah, Thomas, you're already an expert with HRV. You're getting it just right. I do not know, but there is a paper that shows that RA as a group, that their entire autonomic profile shifts towards the sympathetic, like all of them do. And that's true for a lot of diseases. Probably not surprising, but I'm not aware of a study in the Native Americans, and I'd love to do it. It wouldn't be hard to do. We could do it in Washington.
We have a question from Steve Overman, and a superb talk supporting mind-body connection. Do you have any comments on polyvagal theory and the art of medicine?
You know, let's give Steve the credit he deserves. He has been out there championing this for a long time. Steve, you've been a hero to me for years. Thanks for all the hard work you did. Yeah, although polyvagal has kind of gone in a different direction, and I know you have a group that I went to a couple of times. I think I made them irritated more than anything else. But yeah, the answer is yes. This is the mind-body connection. I think we're all dancing around the same fire. I'm trying to be as mathematical and specific as I can. I'm trying to do what Peter Simpkin taught me to look for the pearl, and what Mark Manick taught me to be very critical with robust evidence. So I think the polyvagal just, we're all in the same camp. So I think you're right.
And a question from Mark Wenner. Andy, thank you for such a fascinating talk. Is there data about relationship between ANS and spontaneous somatic gene variation with aging, in parentheses, clonal hematopoiesis of indeterminate potential, CHIP?
Well, again, Mark, you could have made $10 if you just called me ahead with that and with that question. But I think with those questions, Thomas and Mark, thank you for your question. We ought to get together. Let's bring in Lee Hood. Let's bring in some other minds. And I'll throw in the clinical part. Maybe I can be some glue to bring them together. And let's kick some of those more sophisticated scientific questions around. Yeah. He's in our neighborhood. We can do it.
So Mark continues with another question. Has anyone looked back at the fate of patients with ulcers who used to get vagotomy for treatment?
No, but I was curious about that myself. Yeah. Now, remember, my bias, and all deference to Kevin Tracy and the hard work with vagus nerve and Paul Peter Tack, I'm mostly focused on the central regulatory force of balancing the autonomic, parasympathetic, sympathetic in the central brain. So that's where most of my interest is. How do we get that balance back? But I think some of these illustrations, like vagotomy, I would think the vagotomy is fairly selective and probably didn't inhibit fibers to the spleen, but you have to correct me on the surgical technique. But it wouldn't really be a problem if you did a vagotomy at the stomach. So you wouldn't think so.
So we don't have any typed questions, but I'm going to ask you one more thing, which is, so smoking is a risk factor for RA, and you told us that nicotine might actually be helpful. So smoke-free nicotine, or, is that a good idea?
I think maybe in a mouse with CIA. That's what evidence. I was hoping that you'd bring the Scandinavian team in with Lars Klarskog, and he and I've talked as well, and his wonderful work in cigarette smoking. Cigarette smoking has many implications. In terms of antigen stimulation, all kinds of things, and Michael Huller's, all kinds of things. But it is fundamentally a sympathetic arousal. It is a prominent sympathetic arousal. So you can either smoke, or someone can just kick you in the leg every moment. It will activate this part of the autonomic nervous system. It will amplify your immune responses. So we have to take that confounding business in. So I think it's just best not to smoke cigarettes. I think what we're looking at here philosophically is we need alternatives that patients can take that are easy and scalable. Vagus nerve will be part of the solution, but if there's an external one, we'll see where that goes. And then lorazepam and clonazepam look remarkably promising, but they're benzodiazepines, and we don't need a benzodiazepine problem. But remission is more important right now if you're just using a restless leg dose. So we need solutions, and it's going to be very exciting to see where drug discovery, drug repurposing, other options come to optimize the autonomic state. So.
All right. Well, let me thank you again for coming and giving us a really fascinating seminar with lots of great questions. And